Today we'll be talking about thoracic biomechanical dysfunctions, specifically the transverse and subluxation, and one we haven't come across before, the anterior subluxation. We'll also be talking about some of the pertinent applied biomechanics as far as assessment is concerned, and also an overview of their treatment. Okay, so movement of the ribs. Basically, you've got three types of movement: pump handle in the upper 2 or 3 ribs, bucket handle, the rest of them except for the lower 2 floating ribs, and basically the floating ribs, which does medial and lateral rotations, or the caliper action. Now, whether or not you're breathing, the ribs are moving in bucket handle or pump handle movement depends to a large extent on the angle of attack of the rib to the vertebral body. And what you can see in this diagram is that we've got this side, actually it's angled much more anterior posterior than the other side, which is much more oblique. Now, most of the movement at the costovertebral and costotransverse joints is a rotational movement, so it's a spin around the neck of the rib, and basically what it means is the rib can either move, if it's coming in like on this angle there, so this is hitting the vertebra there, if it spins it will do that. If it's coming in more at that angle, it'll do that. So pump handle ribs tend to be those that are coming in much more horizontally, such as this one, whereas bucket handle ribs are coming in more vertically. Now, there is no clear-cut transition between pump handle and bucket handle ribs. You can imagine that the angle that the transverse process makes to the vertebral body is going to gradually alter itself as you go down. But it's, in general, the upper ribs, 2 or 3 ribs, are going to be mostly pump handle movement, while the rest of them, except for the lower 2, will be bucket handle to a certain extent. There's a transitional area where it's doing a bit of both, and that's probably from about 4 through 6. So this is a way you can see how these ribs work. So the lower 2 ribs actually move in and out this way. The main function of the lower 2 ribs, though, is not to aid in inspiration or expiration. The main function that they have is to hold the base of the diaphragm. And you've got a big muscle across here, and you need a couple of bones to hold on to this, and this is what they do. Okay, so this is the same glide we just looked at, but we're going to be talking about the arthrokinematics of these movements. Now, because of the attachment of the costotransverse and the costovertebral joint, the rib has a minimal amount of ability to angulate. So most of this movement, as we said in the previous look, it's actually a spin around the neck of the axis, but there is gliding occurring there. And the 2 axes, the XY axes and the XX axis and the YY axes, these and that, are the angles they seem to glide from. So the glides here are obviously going to be dorsolateral and ventromedial, and these are the ones that we'll test. Now, whether it glides dorsolaterally or ventromedially during inspiration and expiration depends exactly what type of movement the rib's doing. So if this is a pump handle movement you're checking, then basically as you inspire, it does that. So this thing goes ventromedially during inspiration and dorsolaterally during expiration. So this is what it's doing, this rocking movement. With the bucket handle ribs, basically they're going dorsolaterally with inspiration and ventromedially with expiration. So they reverse themselves. Pump handle movements move in the opposite, glide in the opposite direction to bucket handle ribs. So these are going to be our glides. They're not the most easiest thing to feel, but once you get the hang of them, they're not difficult. Okay, so we've seen this before in the lumbar spine. Actually, you've also seen it in the cervical spine, but we just named it something different. The unconvertible joint dysfunction does exactly the same thing, basically. It causes it to translate and also side flex, so tips and slides or slides and tips. It's fairly easy to understand how you can do it with the unconvertible joint, and that can be extended down into the ribs, at least from the third rib down to the ninth rib, because the head of the rib projects upwards and articulates with the superior vertebra. So these act as uncinate processes essentially, and you can see how the same mechanism would be applied. Lumbar spine is much more difficult to really envisage. We're going on the fact that it seems to happen, but here we can sort of work out a mechanism for it. Now, I would assume would be the costovertebral joint and the projection up into the superior vertebra. Anyway, so we know that it translates over across the disc that way. It side flexes and it rotates. Now I can't draw the rotation here, but imagine this one, or it turning in that plane. So in this case, it will be translated to the left side, bent to the left, and rotated to the right. We basically pick it up the same way as we do in the lumbar spine. You palpate, if you do the easiest way is by far is with position testing. You palpate the transverse processes, you'll find that one's posterior in flexion, you'll also find it also posterior in extension and neutral if you can feel it. So what we have is a vertebra that's rotated to the side where the transverse process is posterior. In the lumbar spine, we treated that by translating across, but there is also a rotational manipulation that you can do as well. In the thorax, it's pretty much the same thing. You palpate position, do your P-pivums, that is try to de-rotate it, and you find it can't de-rotate. It's rotated, in this case, to the right in all positions. So it's translational subluxation. You test the hypothesis by translating it both ways. Whichever way it doesn't go is sublux in the opposite direction. So in this case, I would not be able to push this to the right. So the diagnosis would either be a left translational subluxation or a right rotational subluxation, depending on how you want to model it. Trying to de-rotate this with manipulation doesn't work anywhere near as well as it does in the lumbar spine. You get bounced off it. There's often a very springy infield, and this is often the way this diagnosis is made. Actually, it's a failure of the manipulation, the reaction you get when you try to manipulate it, and it leads you to look in more detail at the translation. So we've seen this one before. There's nothing new about it, and it's fairly standard. The second one, on the other hand, isn't as standard. And basically, this is an anterior subluxation, or it's often termed a bilateral flexion subluxation. But again, the problem seems not to lie at the facet joints, but across the segment that way. So the whole thing shifts forward, and as it shifts forwards, it tips forward into flexion. Now, this one cannot be picked up by position testing because there's no asymmetry. The whole vertebra is shifted forward, so both transverse processes are much the same. Now, these can be either extremely painful or completely asymptomatic, and stuff in between. I've actually treated one of these in the cardiac unit. The patient had been admitted with suspected heart attack. It's a bad one. He had a lot of pain, anterior and posterior chest pain. And they ran all the tests and everything else. They asked therapy to come up. I looked at him, did a traction manipulation, and the pain went away almost immediately. So these can be that bad, or they're completely asymptomatic, and you only find them because you're looking for them to explain why the shoulder is having difficulties, or why you've got a lower quadrant problem, and this may be the fact that this segment can no longer extend, and you can't release the extension forces by movement, so it concentrates the forces below it. So you either find it because it's painful, or you find it because you're looking for an etiology. If this is painful, one way to detect this is with PAs. Now, if I do a PA on the superior vertebra, that's going to increase the pain exponentially if this is seriously painful. And the patients are going to love you for it. If, on the other hand, I push this one forward, which is doing the same thing, but differently now, it's going to jam up. It can be very painful as well, but it's going to jam up. So what you find is, if it's painful, the superior vertebra is extremely painful to a PA. The bottom one is less painful to PA and it feels jammed. If it's not painful, you do the same thing again, but now you have to rely on end fill. So we push this one forward, and the end fill will be movable. It'll be more normal. It won't be normal by any means, but it'll be more normal. And if you push this one forward, it will just jam up on you. So this is how you find this. As I say, it can be extremely painful or it can be asymptomatic, but it's an etiology and you're looking for something that can't allow extension to occur because the problem you're dealing with has been caused by an extension force. So, as I said, this is new to you. Actually, you see this on X-ray sometimes. Now, whether it's the same thing or not, I don't know. But you do see this as an incidental finding on a lot of X-rays, is a thing sitting that way. And it's not, the vertebra isn't deformed or anything, it's just shifted forward. Okay, so we've looked at treatment for the translational subluxation, and basically we could do a lift or a drop technique. So if we was doing a lift technique, we would basically fix the lower vertebra and lift the superior vertebra. So you bring it up, let it go, and the thing generally does what you want it to do. This will you tend to use on smaller patients or higher levels where your arm strength is what's being used. If we have a bigger patient, then we tend to use a drop technique. And in this case, we fix the top vertebra and basically drop the bottom vertebra and let gravity do the work for us. A little bit more athletic, a little bit more agility required for that, but we can use this on bigger people at lower levels of the spine. Same thing applies to the anterior one. We can basically fix the lower vertebra and lift the superior one, or we can fix the inferior one and lift the superior, and the effect for both is the same, and you pick the same criteria. Lighter patients, higher levels, you would tend to lift it. Heavier patients, lower level, and you would tend to drop it. So the techniques are pretty much the same as you're used to. There's obviously detail different, the way you're going to grab the patient with this, but essentially the principles are the same. Unfortunately, in the lumbar spine, the patient's heavy, and the area is a bad one, and I'm not sure that you was taught this on the lumbar course or not. I tend not to teach it on the introductory levels because it's a little bit dangerous for the therapist until you get used to using your body better than you probably are using it right now. But either way, you will learn this for the lumbar spine as well. Now, we can do traction in sitting, or we can do traction in laying. I should also mention this. There is another technique in prone, and I don't really like this one very much, where you fix here and you thrust that one back that way. So it's a direct dorsal shear. It does put a lot of stress on the disc, and you have no idea the state of the disc when you're doing it. So whenever I can avoid that, I do avoid doing that one. All right, rib subluxations. These are modelled as occurring at the costotransverse joint. And it may not be. It may well be at the costovertebral joint or at both. But what we're modelling this way, and it's an easy way to imagine it, because the manipulation that's primarily used is a distraction manipulation of this joint. Now, you can manipulate dorsolateral and ventromedial glides, but they're more difficult to do. And if the easy one, the costotransverse distraction technique, works, there's no reason to even think about the other two. And this does work. This works probably 95% of the time. There are also thumb techniques you can use instead of the formalized sort of manipulation, but we'll look at distraction techniques. So we're going to have the patient lay in supine, and essentially what we're going to do is fix the rib now here, and as close to the joint as we can get, and we're going to thrust the vertebra backwards. So we're moving that in that way, and it's going to gap that joint like so. And as I say, it's a nice, easy technique. The nice thing about it is you almost always get little pops out of this when you get it. So everybody's happier when it's done than when it's not done. And it's very effective. So that's the principles of the technique we're going to be using here. As I say, it's a simple enough technique, doesn't take an awful lot of skill or effort. And the most difficult part is getting close enough to the transverse process so that you can stabilize the rib there. You want to be careful though, if you come onto the transverse process, you're essentially back to manipulating the facet joint again, which is not, of course, what you want to do. So it's just a matter of carrying your palpation and then applying the dorsal thrust. Okay, so this depicts the traction technique, and the pressure is actually under the infrascapular tubercle, not across the elbows. So you can see with the left-hand photograph, this is a lift technique, and it's not done with your spine, it's not done with anything other than your scapula, and you essentially elevate and retract your scapula to do that movement. So as I say, you can't really do this on a big person or at a very low level. The other technique you're looking at there is the drop technique, and you fix a vertebra above, usually with a towel or something from your chest, and you simply, again, the pressure is underneath the infrascapular area there, and you simply drop them away from it so gravity takes them down. Both effective techniques, it's a matter of picking the one you want to do. Now you can also use this as a dorsal shear for the anterior joint. It's probably safer than the supine technique, but you would fix the vertebra below the level of the target, well, the lower vertebra of the target segment, and this time you would pull your arms backwards this way, and you're going to pull the top vertebra back onto the bottom vertebra. If you can feel the end feel properly and like wiggle them around a bit and find the end feel, you can actually get it to like come into extension a little bit as well as you do it. But that's basically the technique, the traction technique for the for either of them actually, the anterior subluxation or the transverse subluxation, and also a dorsal shear technique for the anterior subluxation. But I would go for traction before I went to any of the other techniques. It's less stressful. Okay, this is another way of doing the distraction technique. For some reason he's doing it on the floor, I'm not sure why, he looks very awkward there. But you do it on a bed. So what you're seeing is that he is moving this way. So he's fixing the lower vertebra with his right hand, and he's thrusting his downward push on this to stabilize his body position. He's lunging up the bed, producing this distraction force there. It's an effective technique, and it can also be used as a prelim to doing a transverse shear technique, which you might learn, and that's a direct thrust out of the subluxation under that form of traction. Okay, hope that was helpful to you. And any questions, email me. Take care, everybody. Bye-bye.